Hello, I'm Sujit Sheth. I'm professor of pediatrics at Weill Cornell Medicine and lead the thalassemia program here at New York Presbyterian Hospital. Today we're going to talk about transition of children with chronic illness to the adult side and some of the issues surrounding that and how we can facilitate that transition and make things better for them as they move forward. These are my disclosures. So these are some of the common chronic diseases in children. Diseases in which there's a prolonged course requiring a lot of medical attention and where transition really becomes an important key element in order to facilitate the continued care at the same level and improve outcomes as patients move forward. Children with these diseases have had better outcomes since the advent of novel therapeutics as well as advances in medical care, which makes this even more important because the adult providers may not have as much experience with these disorders, and therefore transition is really key. So some of the diseases include sickle cell disease, cystic fibrosis, inflammatory bowel disease, congenital heart disease, thalassemia, and asthma. Transition has been recognized as a priority by several very prominent organizations, including the American Academy of Pediatrics, which has a Bright Futures framework that gives you guidance in terms of how transition may be facilitated, the American Academy of Family Physicians, the American College of Physicians, and the American Society of Internal Medicine. The scope of the issue is actually quite broad. In 2009 and 10, the National Survey of Children with Special Needs found that there's an estimated 4.5 million youths aged 12 to 18 years with special healthcare needs. So all of these patients, as they get older, would need to be transitioned to adult providers. 80% of these youth are living into adulthood, yet 60% of them are not currently receiving transition preparation. So in order for transition to go smoothly, these individuals need to be prepared, need to understand what they will encounter on the adult side and be prepared for that. This is becoming more and more of an issue as children who would otherwise have succumbed to their illnesses, things like congenital heart disease, are now surviving much better because of advances in medical care. So why is transition an issue? The age group that we're talking about, the 12 to 18 or 16 to 20-year-olds, have that period has a lot of changes that are ongoing in those individuals' lives. These are physical changes as they grow and develop, physical changes that might affect their disease itself. There's a lot of psychosocial issues related to school, graduating school, going to college, things like that. Issues related to freedom and independence. This is a time when typical teenagers are starting to leave home, go to college, and become more independent, whereas these individuals with chronic illness may not be able to do that. There are also issues of reduced supervision, where parents are now expecting their children to take care of themselves much more so without direct supervision. And then there are issues related to peer pressure, where friends and others may influence the way in which you live your life and do things that might put you at higher risk, for instance, smoking, substance abuse, things like that. Transition is also an issue because unless you're prepared and your family is prepared, this could not go very well, and that could end up affecting the transition of care, the continuity of care, and outcomes as a result of that. There's also a lot of parental anxiety, and this relates to the idea of letting go. These are parents who've taken care of these kids since they were born, sometimes with these chronic illnesses, and now feel like giving up control over that care. What if the child doesn't or the young adult is not able to take care of himself or herself well enough? There's anxiety around that. There's also anxiety around a new provider team and how the patient as well as the family member will interact with that team and how comfortable they will feel with that team. Internists may also lack some experience dealing with young adults with chronic illness. These are not your typical 18 and 20-year-olds who are transitioning over to adult care. These are individuals who have a lot of baggage. They have a lot of physical issues, psychosocial issues, and internists may not be really well prepared to deal with that. There are special issues with children with chronic illness, and these include things like growth and development, including sexual development, which may not be normal, which may have been delayed as a result of that illness. They may have abnormal physical habitus. They may be dysmorphism, skeletal abnormalities, things that make them stand out from their peers. They may not be psychologically mature for age. They may not have a clear understanding of their disease or the treatment of that disease, the need for compliance, how important that would be for better outcomes. And they may not be able to cope with transition as a whole. New people, sometimes a new physical facility, and that might really be a big challenge as well. They may be in school, they may have dropped out, and going again to adulthood and having to assume more responsibility for your own care might be more challenging as well. There are challenges for adult providers as well. There may be a general lack of experience with young adults, especially surrounding psychosocial issues. Adult providers are very well experienced dealing with 30s and 40s and 50s and 60-year-olds, may not be so well experienced with dealing with teenagers or 20-year-olds. They may not be experienced with dealing with parents, especially parents who have not relinquished control completely or even partially to the patient himself or herself. They may have expectations of the patient that may not be that appropriate, expecting their patient to be more independent, to be able to make decisions independently, snap decisions on the spot, whereas young adults may need to consult with their parents or siblings when making such decisions. Adult providers have a different approach to care in general, just in terms of how they might perceive their patient and what expectations they may have of their patient in terms of following through, compliance, making appointments, things like that. There may be differences in the care paradigm in terms of who sees these patients when they come in for visits, whether it's a doctor, whether it's an advanced practice provider, and how that whole paradigm of care is different may cause anxiety as well. The ability to use different agents in adults, which may not be approved for children, is something else that is going to be new to these patients. They're going to be told, hey, look, you're now 18 or 19 or 20, and you're eligible to get this particular medication, which you couldn't get as a pediatric patient. And that's going to cause a little bit more anxiety in the patient, as well as a challenge for the adult provider to explain to a patient who may not be as mature about these new agents. And then adult providers as a whole may have a lack of experience treating some of these children who are now living to adulthood, who may previously have died earlier. And therefore, there's not enough of a critical mass for that they might have seen during their training. And so this might be something that also has to be considered. There are several barriers to effective transition. The most important of these, in my opinion, is a lack of preparedness, both from the patient standpoint as well as the parent standpoint. Sometimes this transition occurs precipitously, and sometimes it's forced on by an admission, or a patient who's not been seen for a year now suddenly has outgrown their pediatric practice and now needs to be seen by an adult provider, and it all happens all of a sudden, and there's no preparation and there's no smooth transition. It's a completely new team that the patient and family is dealing with, including other specialists. So if you have a primary disease that is, say, a gastrointestinal disorder, you may also need to see other specialists. For instance, an endocrinologist or a renal specialist or a cardiologist. And so when you transition your primary specialty, you also have to transition all of these other specialties as well. So that may be a big challenge as well. We mentioned the different approach of adult providers. The different physical environment is also sometimes a big challenge. Many of these patients are taken care of in children's hospitals, freestanding children's hospitals that don't have an attached adult hospital. And sometimes they have to go several miles away to the adult hospital. And that makes transition more challenging because it's very hard then for the pediatric provider and the adult provider to see the patient at the same time to facilitate the transition. If requiring admission, again, there are differences between inpatient care for pediatric patients and for adult patients. Just the way in which care is set up on adult floors is very different than the pediatric floor as well. So preparing patients for that is sometimes a challenge as well. Specific to thalassemia care, most of the comprehensive thalassemia programs are in children's hospitals, and transition involves going to a different facility. In late adolescence, this is a time when compliance is severely tested, and compliance with care in thalassemia is absolutely critical to make sure that the patient is in the best possible shape and has the best possible outcome. And as we all know, as teenagers, we were not the best in terms of following through on everything we were instructed to do, and the same applies to individuals with chronic illness as well. So this is a challenging time. These individuals may have delayed growth in puberty as a result of the iron overload, and that might be an issue. There are chronic psychological issues that they deal with. And then they really lose a stable relationship that they've had with their pediatric provider or pediatric team for a number of years. And now they have to move over to an adult provider. So that causes a lot of anxiety for them. Graduation and college, going away and getting their transfusions remotely at a different institution, that adds to stress, and then they have to come back and sort of re-engage with the hospital that they left behind, which may now have changed because they've transitioned from a pediatric practice to an adult practice. There's a new team of other specialists, including cardiologists, endocrinologists, and other providers as well. And there's the availability of a new agent, which is luspatercept, which is approved for use in 18 and over only. So the transition process that I think would be good to set up for a number of these chronic illnesses. I'm breaking it up into 3 6-month periods, which would last about a year and a half. So we begin the process at about 18 to 19 years of age. We have social work or a clinical psychologist assess the patient and the family for readiness for transition. This is really important because if they're not ready, it's probably not going to go very well. You can involve adolescent medicine if possible at the institution. Begin the discussion with both parents and the patient, oftentimes together, building expectations of both for this transition to go smoothly and successfully. Identify an adult provider with the most experience in that particular disease, and if they have taken patients from the pediatric provider before, that helps because that means there's a relationship between the pediatric and adult provider as well. Send detailed information during that first 6 months to the adult provider to review all of the medical records, which oftentimes is now quite easy because the electronic medical record may be shared, and therefore you may be able to see these records directly. And then make a detailed transition plan, put it in writing, make sure that the expectations are clear with the patient and the family as well. In the next 6 months, have the patient see the adult provider, just a preliminary visit to as a meet and greet kind of visit with the parents in attendance as well. And then just go over that transition plan with the adult provider and say, this is what was provided to me, this is how we're going to do this, and let's talk about all of the different steps. Take a tour of the physical environment of the adult facility as well. Have a transition meeting between the pediatric and adult teams and discuss all of the issues relevant to that specific patient. If there are specific issues, psychosocial issues or family issues, make sure that the adult team is well aware of them as well. discuss all of the medical and psychosocial issues, and set some expectations of the team. Have a frank discussion of the barriers to smooth transition, not just for that patient specifically, but in general as well. And then start to provide the patient with some autonomy in decision making. So this patient is still now with the pediatric team, and providing some autonomy in decision making where the parents are not making those decisions is a good place to start. Again, the patient has known the pediatric provider for a number of years, and there's a sense of trust and comfort, and this may go well in the pediatric setting to start with, rather than doing it directly in the adult setting. And then transition of care to other specialties. Have one or more of those visits with the adult providers. So make sure that happens before the main visit happens with the primary subspecialist that's going to take care of the patient. This might help because now they have a taste of the adult side. They've started that process while still having continuity with the pediatric team as the primary provider. And in the final 6 months, have the patient see the adult provider for 1 or 2 visits, preferably without the parent, because now you're starting to focus on that autonomy issue. Continue to have 1 or 2 more visits with the pediatric provider to debrief how the adult visit went, as well as continue to fine-tune the plan of care for the future. The pediatric provider discusses the patient's thoughts together with the parents to ensure that everybody is in agreement on the transition, that it has so far worked well, and the next steps will come as you move forward. The pediatric provider continues to communicate with the adult provider, offering ongoing support in the first few months after the transition has occurred. So this is something to start to make sure that plan happens. And then make the official transition on the date that was noted in the written transition plan, unless there's a specific reason to delay it. The pediatric provider obviously will leave channels of communication open with the adult provider, as well as with the patient and the family, with clear understanding that the medical decision-making is now with the adult provider. It's not going to be done by the pediatric provider, but the communication is open, and the patient and the family are still welcome to communicate with the pediatric provider as well. And if all of these things go smoothly, then overall, the transition should go well, and the adult provider should have a well-prepared patient and family who has some autonomy and an understanding of why compliance is important. And all of these things would go a long way in ensuring better outcomes for these individuals with chronic illness.